Welcome to the Radong Smart Review CNS Cancer Series.
Yeah.
Today we're tackling a really critical and often quite nuanced topic in neuro-oncology, the management of low-grade gliomas. And this isn't just about, memorizing facts. It's really about building a solid framework for making precise clinical decisions for, well, a pretty unique patient population.
That's exactly right. Over the next session or so, we're going to walk through pretty much everything from the initial diagnosis and the latest kind of molecular insights, all the way to the really intricate details of treatment planning and, those real-world case scenarios you'll definitely encounter.
Yeah.
And we'll try to solidify understanding with some maybe challenging clinical decision-making examples that should feel pretty close to oral boards.
That's exactly. Our goal here is to give you that comprehensive understanding, kind of putting all that foundational knowledge into practice, exploring how to precisely plan radiation and manage potential toxicities, really make sure you feel confident and prepared. So let's maybe start by setting the stage for World Health Organization, or WHO, grade 2 gliomas. What immediately stands out about these tumors and patients who typically present with them?
Well, what's immediately striking, I think, is the patient population itself. We're often dealing with relatively young individuals, sometimes, in their 20s or 30s. They often have really long life expectancies ahead of them. And this fact, it profoundly shapes our approach.
Right.
It means minimizing those late toxicities, things like neurocognitive decline, hormonal issues, or even the small risk of secondary cancers. It becomes just as crucial as achieving excellent tumor control.
It's a real balancing act.
It's a very delicate balance, yeah, where quality of life is just paramount alongside the oncologic outcomes.
That distinction is so key because unlike, say, higher grade tumors that might demand immediate, really aggressive intervention, these low-grade gliomas, just by their nature, they often don't show rapid enhancement on scans. They're often slow-growing, which kind of means our diagnostic workup has to be incredibly thorough, right, to truly understand what we're dealing with.
It absolutely does. When we suspect a low-grade glioma, the initial workup is just foundational. It always starts with a really comprehensive history and physical examination. We need to confirm the patient has ideally no residual neurologic deficits and maintains a Karnofsky performance status, or KPS, of 100. A patient with symptoms or functional deficits, even mild ones, that might influence our timeline for intervention.
And imaging, well, as always in neuro-oncology, it's just non-negotiable, isn't it?
Oh, indispensable. Yeah. We need both preoperative and postoperative magnetic resonance imaging, or MRI scans. These are vital not just for diagnosis, but also to confirm the extent of surgical resection. But the real game changer in recent years, I think, the piece that often holds the most weight, is the final integrated pathology report.
Okay.
We absolutely need to know the WHO grade, the isocitrate dehydrogenase, or IDH, mutation status, and crucially, the 1p and 19q co-deletion status. Those are key.
And this isn't a decision made in a vacuum either. It's a team effort.
Not at all. It truly necessitates a robust multidisciplinary discussion. A referral to neuro-oncology is almost always a given. It brings in the surgeons, medical oncologists, and often neuropathologists to weigh in. Every perspective really helps refine the plan.
Okay, so once we have all that rich information, the next critical step is risk stratification. For these low-grade gliomas, how do we use criteria like the Pignati criteria to guide our decision-making, thinking about factors like age, resection extent, tumor size, midline crossing?
Well, that leads us right into the pathology, which has seen some truly transformative updates recently. What's really fascinating, I think, is how specific pathological features and these molecular markers are now fundamentally driving our understanding and treatment decisions. It's far beyond just what we see under the microscope now. For WHO grade 2 gliomas, the IDH mutation status and that 119q co-deletion status are, like you mentioned, absolutely critical. They're just central to the modern classification.
But there's that one molecular marker that, if it's present, it just completely rewrites the story of the tumor. Doesn't matter what else you see.
Yeah, you've absolutely hit on the most impactful change. The homozygous deletion of the CDKN2A and B gene. This isn't just, a slight adjustment in classification.
No.
It's a profound molecular discovery. It tells us these tumors, even if they initially look like a totally benign grade 2 under the microscope, they harbor an aggressive, really high-risk biology. This finding automatically upgrades a tumor to an astrocytoma, IDH mutant, WHO grade 4. Regardless of any other clinical factors. It just fundamentally alters our treatment strategy, maybe from watchful waiting straight to immediate aggressive intervention. It's a stark reminder that what we see on a scan isn't always the full story. The genetics are kind of the real crystal ball these days.
So, okay, with all that crucial diagnostic information in hand, let's shift gears a bit to the meticulous process of modern radiation planning for these low-grade gliomas. Given the patient profile we discussed, young, long life expectancy precision here isn't just a goal, it's paramount.
It absolutely is, yeah. Let's walk through the steps. Maybe imagine you're sitting down to plan one of these cases. It starts with the CT simulation. We immobilize the patient, supine position, typically with a custom thermoplastic mask. That ensures reproducibility day to day.
Right.
We acquire a thin slice, contrast-enhanced computed tomography or CT scan. But here's where the art and science really merge: the image fusion. This is arguably the most critical step. You must fuse the planning CT with the patient's diagnostic MRI scans. For a low-grade glioma, this requires, at a bare minimum, the postoperative T2 Fellaire sequence. And really, as best practice, you should always try to fuse the preoperative MRI as well. It helps you fully appreciate the original tumor extent before any surgical changes. Gives you that complete picture of the disease.
Got it. So when it comes to defining the gross tumor volume, the GTV, for low-grade gliomas, it's a different ballgame compared to, say, a glioblastoma, where you might be looking for that bright contrast enhancement.
That's a crucial distinction, yeah. The cardinal rule, really, of low-grade glioma planning is that for these typically non-enhancing tumors, the entire T2 and FLAIR hyperintense signal represents the gross tumor. You can almost imagine like a specific type of MRI image where the tumor, even if it's not obviously glowing with contrast, it lights up subtly, almost like a faint halo. That shows us its full extent, including any sort of hidden tendrils. So your GTV should be a really careful contour of this abnormality, and importantly, including the surgical cavity.
Right.
From there, we create the clinical target volume, or CTV. Landmark trials like RTOG 9802 and EORDC 233, they used CTV margins of about 1 to 2 centimeters. In modern intensity modulated radiation therapy, or IMRT, a 1.5 centimeter isotropic expansion from the GTV is pretty much a widely accepted standard now.
And the CTV isn't just a simple geometric expansion, is it? You have to be incredibly thoughtful about the anatomy around it.
Absolutely. The CTV is really an anatomical concept, so it has to be edited or trimmed to respect the natural barriers to tumor spread in the brain. A good mnemonic to remember is that gliomas generally respect BDT, that's bone, dura, and the tentorium.
BDT.
Yeah.
Okay.
So you should trim the CTV flush with the inner table of the skull, the falx cerebri, that tough membrane dividing the hemispheres, and the tentorium cerebelli, that sort of tent-like structure over the cerebellum. Think of them like natural fences in the brain.
Makes sense. But there's a vital exception to that trimming rule, isn't there? One that can really trip you up if you're not careful.
Indeed, there is, and it's critical for board exams and, more importantly, patient safety. You must not trim the CTV at the corpus callosum if the tumor is nearby.
Why is that?
Because this is a primary route for contralateral spread. It's basically a superhighway for tumor cells between the hemispheres, so we absolutely cannot assume it acts as a barrier. You have to include it.
Got it. No trimming at the corpus callosum if the tumor's close.
Exactly. Then, after the CTV, we define the planning target volume, or PTV. This is a geometric expansion, usually about 3 to 5 millimeters, just to account for setup uncertainty, tiny day-to-day variations. And unlike the CTV, the PTV should not be trimmed.
Okay, so to put it simply for our listeners, when we talk about the PTV, it's almost like we're building a little safety net around the tumor, right? Like imagine you're trying to hit a bullseye, but you know your hand might shake a tiny bit, or maybe the target might wobble slightly. The PTV is that extra bit of space you aim for, just to make sure you definitely cover the entire bullseye, accounting for those slight movements or maybe inaccuracies during treatment delivery, just ensuring the whole target gets the intended dose.
That's a perfect analogy. Yeah, exactly. And the standard prescription for low-grade gliomas is typically 50.4 gray, up to maybe 54 gray, delivered in 1.8 gray fractions. And this isn't just some arbitrary number. It's really based on definitive negative dose escalation trials. Things like EOECC 22844 and NCCTG 867251.
Right, the dose escalation trials.
Yeah, they definitively showed that higher doses just increase toxicity without any survival gain. So in this case, more isn't better, it's just more toxic.
54 gray max. Got it. So we're not just, blasting away. We're being very mindful of protecting those surrounding structures that are critical for patient function and especially quality of life long term. What are some of those key organ at risk, or OAR, constraints we absolutely need to have memorized, like the must-knows?
For sure. You definitely need to know these cold for exams and practice. We aim to keep the brainstem Dmax, the maximum point dose, less than 54 gray. Same for the optic chiasm and optic nerves, Dmax less than 54 to 55 gray. That's crucial for preserving vision.
Okay.
Then hearing. The mean dose to at least one cochlea should ideally be less than 45 gray, but honestly, for these young patients, we always strive for less than 35 grays if we can, to protect hearing as much as possible. And vitally, the lens DVAX should be kept below 10 gray. That's to minimize the risk of cataracts developing later on.
Makes sense. So beyond just the technical planning, counseling patients about potential toxicities is obviously a huge part of the process, especially for a condition like this that really affects long-term quality of life. What do we typically discuss with patients regarding, say, acute versus late effects?
Right, we cover both. The acute toxicities are generally pretty mild and transient. Things like fatigue, some temporary hair loss just in the treatment field, maybe mild skin redness or erythema. These usually resolve pretty quickly after treatment finishes.
Okay.
The late toxicities, though, those are our primary long-term concern. Neurocognitive decline is often the most feared effect, and honestly, it's a main reason we might choose to defer radiation therapy when observation is a safe initial option.
Right.
Radiation necrosis is another one. It's rare, thankfully, but can be serious. The risk is kept very low by sticking to that 54 gray maximum prescription. There's also a risk of endocrinopathy hormone problems if the hypothalamus or pituitary gland are within or near the radiation field. And finally, there's a small but real lifetime risk of a radiation-induced second malignancy.
So balancing those risks against tumor control, that's an ongoing conversation with the patient.
Absolutely. It's a continuous dialogue.
All right, now that we've laid quite a bit of groundwork, let's move into our clinical decision-making segment. This is where we really apply all this knowledge to some challenging, kind of oral board-style case scenarios. Think of these as your practice questions.
Okay, let's dive into case one. Imagine you've got a 32-year-old architect, prime of his career, who presents to the emergency department after his first ever focal seizure. An MRI reveals a 3-centimeter non-enhancing mass with some subtle calcifications up in the right frontal lobe. He undergoes a gross total resection. You are the first oncologist to see him post-op. What are the key components of your initial workup and consultation for this patient?
Okay, so first step is always a meticulous, complete history and physical exam. I need to confirm he has no residual neurologic deficits and hopefully a KPS of 100. I'd absolutely ensure I have all the necessary imaging, specifically both the preoperative and the postoperative MRIs, so I can confirm the extent of that resection myself. But the absolute bedrock here, the most crucial piece, is that final integrated pathology report. I need to know the WHO grade, the IDH mutation status, and that 119q co-deletion status. And of course, this needs a multidisciplinary discussion. Neuro-oncology referral is non-negotiable.
Excellent. Okay, so the final pathology report comes back. Oligodendroglioma, IDH mutant, 1P and 19q co-deleted, WHO grade 2. He has that KPS of 100, no neurologic deficits. Given this information, what are his management options and what would you recommend?
All right, so this patient presents as a pretty clearly low-risk grade 2 glioma. I'd use the Pignati criteria to risk stratify him. He's under 40, he had a gross total resection, and he has the favorable oligodendroglioma histology with the co-deletion. Critically, he has 0 high-risk factors. Therefore, my primary recommendation would be active surveillance with serial MRIs.
Okay. And your justification?
I justify this based on the low-risk observation arm of the RTG 9802 trial that showed a 5-year progression-free survival of roughly 50% for similar patients managed with observation low initially. So I would counsel them this is a safe initial approach, but it absolutely requires diligent, lifelong monitoring, and importantly, there is a significant chance he will need active treatment down the road. We need to be upfront about that.
Perfect rationale. Okay, let's move to a more complex scenario now. Case 2. Your next patient is a 50-year-old man. He presents with several months of worsening headaches and some subtle word-finding difficulty. An MRI reveals a large, 7-centimeter non-enhancing T2 flare-high hyperintense mass in his left temporal lobe. It's extending into the insula and, crossing the midline via the corpus callosum. A subtotal resection is performed. The diagnosis comes back, astrocytoma, IDH mutant, WHO grade 2. He has ongoing mild dysphagia post-op. What is your initial treatment recommendation here?
Okay, this patient unequivocally has a high-risk grade 2 astrocytoma. He takes multiple Pignati risk factors, age over 40, tumor size well over 6 centimeters, and crucially, it's crossing the midline. So the standard of care for high-risk, low-grade glioma is combined modality therapy, and that's firmly rooted in the results of RTOG 9802.
Right.
I would recommend immediate adjuvant radiation followed by chemotherapy. Given his ongoing symptoms and the high-risk features, deferring treatment just wouldn't be appropriate here.
That's a very clear rationale. Okay, the patient agrees to proceed with your recommendation. Could you outline your radiation treatment plan in detail for him?
Sure. My prescription would be 54 gray delivered in 30 fractions, so 1.8 gray per fraction. I justified this dose based on those definitive negative dose escalation trials we talked about, EOTC 22844 and NCCTG 867251, which showed higher doses just add toxicity, no survival benefit. For the GTV, it's the entire T2 and full layer abnormality seen on the preoperative MRI, making sure to include the surgical cavity from the post-op scan. The CTV is then a 1.5 centimeter isotropic expansion on that GTV. And a critical point for this specific case, given his tumor involves the corpus callosum, I would not turn the CTV at the midline. We need to ensure that common pathway of spread is fully treated.
Very important point.
Exactly. The PTV would then be a standard 3 millimeter expansion on the CTV to account for setup.
A very thorough plan. And what about your chemotherapy recommendation for this particular patient?
So following the radiation, I would recommend adjuvant temozolomide, or TMZ. Now, historically, RTUG 9802 used PCV chemotherapy. However, the more recent Canon trial, which specifically looked at anaplastic astrocytomas, showed a clear survival benefit with adjuvant TMZ.
Wait, that was important data.
Yeah, and given the significantly better toxicity profile of TMZ compared to PCV, it's now generally the preferred agent for IDH mutant astrocytomas like this one. The standard regimen would be up to 12 cycles, typically dosed at 150 to 200 milligrams per meter squared for 5 days every 28 days.
Excellent. Okay, let's discuss our final patient scenario, case 3. This is a 35-year-old woman. She underwent a gross total resection of a tumor that appeared on imaging and initial histology to be a pretty standard grade 2 astrocytoma. However, the full molecular panel comes back, shows an IDH mutation, ATRX loss, and critically a homozygous deletion of the CDKN2A and B gene. Clinically, she's doing great asymptomatic with the KPS of 100. How does this specific molecular finding completely change her diagnosis and her subsequent management?
Wow, okay. This is truly the type of case that just perfectly highlights the revolution in neuro-oncology diagnostics. That homozygous deletion of CDKN2A and B, it's a major high-risk molecular marker. Per the 2021 WHO classification, that finding automatically upgrades her tumor diagnosis to an astrocytoma, IDH mutant, WHO grade 4.
Grade 4.
Grade 4, yeah. She doesn't have low-grade glioma anymore, despite what the initial histology might have suggested. She has a molecularly defined grade 4 tumor. And that means her prognosis is unfortunately far worse than what a typical grade 2 or even grade 3 astrocytoma would suggest. It basically tells us her tumor is biologically very aggressive.
That's precisely it. So given this profound reclassification based on the moleculars, what is your treatment recommendation for her now?
Well, because she now officially has a WHO grade 4 tumor, observation is absolutely inappropriate, even despite her favorable clinical factors like the gross total resection and being asymptomatic.
Yeah.
Now, while there isn't a specific prospective trial for this exact molecular entity yet, given its aggressive biology, which really closely mirrors that of standard IDH mutant glioblastoma, the most appropriate course is to extrapolate from the glioblastoma treatment paradigm.
Okay.
So I would recommend the full stop protocol. That involves radiation, but 60 grays in 30 fractions this time.
Higher dose.
Higher dose, yeah, with concurrent daily TMZ chemotherapy, followed by 6 to 12 cycles of adjuvant TMZ. And her radiation planning philosophy would also shift. We'd follow GBM principles, where the GTV is typically defined by the surgical cavity and any residual T1 enhancement, and a 1.5 centimeter CTV margin is used. But that CTV generally excludes the surrounding T2 fell layer edema, unlike in low-grade planning. It's a different approach.
Excellent reasoning. These cases truly underscore that journey from basic knowledge to really complex clinical application, especially with the molecular data now. So now let's maybe distill some clinical pearls, those concise, high-yield takeaways that will hopefully stick with you for your boards and, more importantly, for your practice.
Okay, pearl number 1. For low-grade gliomas, always remember the tumor volume for contouring, the GTV, is defined by the T2 and L-Feller hyperintense signal, not T1 enhancement. That's a fundamental distinction from glioblastoma planning. Don't mix them up.
Pearl number 2. While gliomas generally do respect natural anatomical barriers, remember BDT, bone, dura, tentorium, the critical exception, that super highway of spread is the corpus callosum. Always remember to include it in your CTV if the tumor is nearby. It's a very common pathway for contralateral spread.
Pearl number 3. Based on those major dose escalation trials we mentioned, 54 gray remains the standard maximum dose for low-grade gliomas. Higher doses were definitively shown to increase toxicity without improving survival outcomes. So again, more is not always better here.
And finally, pearl number 4. The 2021 WHO classification brings in these powerful molecular markers like the homozygous deletion of CDKN2A and B. That single finding can instantly upgrade a tumor's grade, completely changing the management plan, even in patients who look clinically favorable otherwise. It unmasks that underlying aggressive biology.
All right, those are great pearls. Ready for a quick board blitz? Let's see how well we've connected the dots with just a few questions to solidify those key takeaways.
Let's do it. Okay, question 1. Which imaging sequence is most critical for defining the gross tumor volume in a non-enhancing WHO grade 2 glioma? Is it A, postoperative T1 contrast-enhanced MRI, B, postoperative T2 flare MRI, C, preoperative CT, or D, diffusion-weighted MRI?
Okay, think about that cardinal rule. If you thought B, postoperative T2 flare MRI, you're spot on. For these non-enhancing tumors, the entire T2 and Heller hyperintense signal represents the gross tumor.
Perfect. Question 2. What is the widely accepted standard isotropic expansion from the GTV to create the CTV in modern IMRT planning for low-grade gliomas?
Right.
0.5 centimeters, B, 1.0 centimeters, C, 1.5 centimeters, or D, 2.0 centimeters?
Right, standard margin. The answer is C, 1.5 centimeters. This is the widely accepted standard, really based on those landmark trials for modern IMRT planning in these cases.
Question 3. What is the maximum recommended radiation dose in gray for low-grade gliomas based on those definitive dose escalation trials? A, 50.4 gray, B, 60 gray, C, 45 gray, or D, 66 gray?
Tricky phrasing maybe, with 50.4 and 54 often discussed. But the trials established the lack of benefit above 54 gray. The common prescription is 50.4 to 54 gray. Given the options, the best answer reflecting the trial conclusions on maximum recommended dose before toxicity increases without benefit points towards the lower end established as sufficient. So A, 50.4 gray is often cited as the standard target, with up to 54 being the upper limit before diminishing returns. Let's stick with A as reflecting the core finding against higher doses.
Good clarification. Okay, and our final question number 4. A patient's grade 2 astrocytoma is found to have a homozygous deletion of the CDKN2A and B gene. According to the 2021 WHO classification, how does this change the diagnosis? A, it remains a grade 2 astrocytoma but is considered high risk. B, it is upgraded to a grade 3 astrocytoma. C, it is automatically upgraded to an astrocytoma, IDH mutant, WHO grade 4. Or D, it is reclassified as an oligodendroglioma.
And the answer here, highlighting that huge molecular impact, is C. It is automatically upgraded to an astrocytoma, IDH mutant, WHO grade 4. This is just a critical molecular finding per the 2021 WHO classification that fundamentally alters prognosis and treatment approach.
Yeah, and these molecular updates bring us perfectly, actually, to a quick discussion on controversies and advances, particularly the significant impact of the 2021 WHO classification changes on glioma grading overall. As we just saw with that last question, molecular markers like the CDKN2A and B homozygous deletion can fundamentally reclassify a tumor that looks low-grade under the microscope, pushing it into a much more aggressive treatment paradigm. This is really a profound shift in how we practice neuro-oncology day to day.
Absolutely. And along with these classification changes, we've also seen that evolving landscape of chemotherapy choices, particularly for the IDH mutant astrocytomas. We highlighted the practical shift really from the older PCV regimen towards TMZ. That's largely driven by trial data like Catanon, which showed, comparable efficacy, but with a much, much better toxicity profile for patients. It's always about finding treatments that are both effective and tolerable, especially for these patients who might live for many years.
Exactly.
So to sort of summarize our session today, we really dove deep into the complexities of low-grade glioma management, hopefully setting you up with the foundational knowledge and those practical insights you really need.
Yeah, we covered the meticulous planning workshop, really emphasizing defining the target volume for a grade 2 glioma as that T2 and flare abnormality, plus that precise 1.5 centimeter margin for the CTV, typically treated to 54 gray max.
And we didn't just stop at planning. We reviewed those absolute crucial OAR constraints, the brainstem, optics, Coakley, lens, and the vital importance of patient counseling on toxicities, especially those long-term neurocognitive effects that are so important for these young patients.
Right. And finally, our case reviews, I think, truly helped solidify understanding of managing the different scenarios, the low risk, the high risk, and especially those molecularly upgraded gliomas. It helps you think through those real-world decision points. It's truly a dynamic and rapidly evolving field.
It certainly is. Now, to continue your board preparation, be sure to complete practice oral boards over at radongsmartlearn.com.
And please subscribe to Radong Smart Review for our next comprehensive session. Thanks so much for tuning in.